Let's have a conversation. Let's have a conversation. Yeah. Let's have a conversation. Oh, yeah. Look. Yeah. Hey. Let's have a conversation. Woo. Pick up some gems, life is all you make. Go. We keep it real, we don't talk to fake. Tell them hottest talk show on the net, coming for all the majors. Let's have a conversation. Woo. Pick up some gems, life is all you make. Go. We keep it real, we don't talk to fake. Tell them hottest talk show on the net, coming for all the majors. I think it's time to have a conversation. Let's talk about it. I think it's time to have a conversation. Let's talk about it.
Hello, everyone. This is Michelle Biggs, CEO of My Best Everyday Coaching and Consulting, and the host of Real Conversations with Michelle. I am excited to kick off my Healthy You series for my podcast. And this first episode will focus on medical screenings and more. Did you know? Now, for those of you who are new to my platform, I started this podcast in 2020. And those of you know all the craziness that was going on back then. And as a coach, I wanted to figure out a way that I could help people virtually. And so I started the podcast and really talk about a lot of different topics, lifestyle topics. But my background is HR, 37 years in human resources, just retired last year. My focus of late has been executive and career coaching, as well as life coaching. So this podcast kind of feeds my life coaching energy. And tonight's episode was actually born out of an episode I did in February, March, and it was titled Fitness and Nutrition, was part of my Jumpstart series. So I'm excited about this series because those of you know, and my followers definitely have heard me say this, we are no good to anyone else, including ourselves, no good to ourselves if we're not taking care of ourselves mentally, physically, spiritually, and emotionally. So I'm excited to have a very special guest who is going to help me with this discussion. I'm going to bring up Miss Makeba Felton. Hello, Makeba.
Hello. Good evening,
Hi.
everyone.
How are you?
Doing well. How are you, Michelle?
Good. Why don't you tell my viewers about yourself?
All right. My name is Makeba Felton, and I am a family nurse practitioner. I have been a registered nurse for 30 years, and I'm a family nurse practitioner for now 26 years. And I see patients in a primary care setting. I do take care of patients from age 6 through infinity. And so I have a wealth of different patients that I see in terms of age and demographics.
Good. And tonight, um, I know you and I have talked before. We were engaged in a conversation our sorority chapter did on pause for menopause. And you were just such a wealth of information during that session. I'm like, I don't need to find anybody else. I need to get Makeba for this session, especially after I learned what you did. And let's talk a little bit about what you do as a family nurse practitioner, because I'm not sure a lot of people know the difference between what a family nurse practitioner would do versus, let's say, a physician assistant. So let's talk a little bit about that.
All right. So, as a family nurse practitioner, I have had 4 years of undergraduate college experience and education, and then I went back for additional education to be trained in how to make diagnoses, what lab exams to order, what tests to order, and how to treat patients with different health issues and challenges. And the difference in an RN and a nurse practitioner is an RN is not able to make diagnoses, prescribe medication, order tests, and so forth. A physician's assistant is another individual who has gone to undergraduate for 4 years and they've had some clinical experience before going back to graduate school to obtain their physician's assistant's degree. And they also can make diagnoses, prescribe medication, order labs and tests, and so forth.
Yeah.
And then I work with physicians as well. And of course, physicians have completed their 4 years of undergraduate, 4 years of medical school. And then they also complete their residency, which is determined, the number of years of that is determined by whatever their specialty is. So some will go for 3 years and some will go for a little bit longer. And in my current practice, I work with physicians as well as physician's assistants and other nurse practitioners. And we
Hmm.
collaborate in taking care of patients.
Yeah, and what can you do? Because I know I've been to the doctor for, minor stuff, and sometimes I'll see a physician assistant. When should we get comfortable seeing a physician assistant versus your doctor, right? Because a lot of times we want to see, your main doctor who may or may not be available. But I understand from speaking to you, there are times when a physician assistant or a nurse practitioner can handle a situation. So what would be those situations where seeing a nurse practitioner or a physician assistant would be fine?
For any of your healthcare needs, you can see either a physician's assistant, nurse practitioner, or a physician. And I think what's most important when you're trying to find a primary care provider is that you find someone that you're comfortable with, someone that you can build a relationship with, that you can trust, and you can understand where they're coming from. I have patients that they will not see anyone except for me, no matter
Mm,
what is going on with them. And sometimes that's not a good thing. But we can provide the same care as physicians. We do collaborate with one another. If I have a question, I'll ask the physician. If we have newer physicians in the practice, they'll sometimes ask questions, but we bounce things off of one another on a consistent basis. There
mhm,
are some models of care in which the nurse practitioner collaborates with the physician in terms of they'll work a little bit closely with bouncing patients back and forth between visits. So if it's a physician who has a large patient panel, they may have their patient see the nurse practitioner or physician's assistant kind of alternating with them. For my practice, I see all of my patients for all of their care, from health screenings, wellness visits, chronic follow-up appointments, and acute visits as well.
yeah, and I find that a lot of times when I go into urgent care, I'm not seeing a physician, I may be seeing a nurse
Mhm.
practitioner or a physician assistant, right? Correct?
Yes, that's
Yeah,
correct.
okay,
And I do
alright.
work. I work at Duke Primary Care, and our structure is our urgent cares is set up to where we have more physicians assistants and nurse practitioners. Actually, then we have physicians in the practices that take
Mhm,
care of the patients in the urgent care settings.
okay, alright. Well, let's talk about screenings because I know this topic has come up amongst my friends, and just making sure we understand what screenings we should be making sure that we're going through and when, because oftentimes what I find, Makeba, is we don't pay attention to it until we hear someone's been diagnosed with something, and then it's like, "Oh, I need to go ahead and get my mammogram or my colonoscopy and things like that." So if you can walk us through what are the screenings that individuals should um, take part in, and let's go through the age group. My audience
Okay.
typically has been 30s through 60s, I would say. So let's start with the 30s. So what's the
Okay.
screenings that
Okay.
are important for someone who's in their 30s, and then male, female, if there's anything different for male versus female, let's talk that through as well.
Okay. So what I'll share is I'll share what the recommended screenings are, give you a little bit of information, a little bit of statistics and data. I won't go
Okay.
into treatment because that's a whole nother
Yeah,
conversation.
we're
But
not doing that.
but we'll talk about screenings. And what I tell my patients is that your body is like a car. If you take your car to the shop and get your oil changed and get the maintenance on it, it will give you many more miles than if you wait until your car breaks down. So, just
Mm,
as Michelle said, if you wait until you have problems or you hear if someone else is diagnosed with something, sometimes it's a little bit too late. So, preventative health care and medicine is one of the best ways to ensure that we are taking care of ourselves. If we're not good for ourselves, Michelle has also said this, we're not good to anyone else. And so, it's important for us to take care of ourselves so that we can best take care of those that are around us. And I'll start with age 30. Females in age 30 should be getting their pap smears. The guidelines have changed within the past many years from annually to every 3 to 5 years. And the
mm,
reason it changes because cervical cancer is a slow growing cancer. And so it takes about 7 years for a patient to go from having normal cells on their cervix to having fully blown cervical cancer. And so typically, if the cells are changing, we'll find those within those 3 to 5 years. The
okay.
patients that are in their 30s, I'll screen them closer to the 3 years. As we get into the 40s and 50s, then we can screen every 5 years. Insurances will pay for pap smears annually, but
Okay.
there's really no medical reason to have it done annually unless you've had abnormal pap smears. So if you've
Okay.
had abnormal pap smears, then you do want to get it done a little bit more regularly. Now, the virus HPV is a virus that's sexually transmitted, and it is affiliated with causing cervical cancer. And the theory behind that is that women in their 20s and 30s are a little bit more promiscuous and
Okay.
sexually, and so they're more likely to get STD called HPV, which can lead to cervical cancer. So, for that reason, we do see a higher incidence of cervical cancer in women in their 20s and 30s. As
Hmm.
we get older, that risk declines, and that's why the need for screening, the age, the difference in screening from goes from 3 to 5 years. And so that's a cancer of women in the 20s and 30s. So it's a misnomer when we think about cancer. It's something that affects people when they're older.
And Makeba, I feel like my doctor just started. Well, I shouldn't say just started screening. I became familiar with HPV probably a couple of years ago. So it wasn't something that was done maybe
Mhm.
20 years ago. Like when did they start doing
Correct.
that?
Correct.
Okay.
We've been doing HPV screening probably for about 6 years, maybe 8 years.
Okay.
And so when a woman gets your pap done, you'll get two results back. You'll get the normal pap cells, so that's one component, and then probably a day or two later, you'll get the follow-up results of your HPV screening. And so
Okay.
you really don't know what the next step in terms of follow-up will be until you have both of those results as well.
Okay.
Um, Women after you're 65 no longer need screening for cervical cancer because that risk pretty much goes away as you get to the age of 65. So you'll have
Okay.
your primary care providers, your OBGYNs, which will say you no longer need a pap smear when you're 65. Different cancers are more prevalent at that age, and we'll talk about that when we get to those age groups.
Okay.
Women that have had hysterectomies, if you've had a hysterectomy for reasons of cervical cancer, you do need to have ongoing screening. However, if you've had a hysterectomy for things like uterine fibroids, other benign reasons, you no longer need a pap smear, but you should get an annual exam where you're having a pelvic exam where we're examining your ovaries. And we call it a bimanual exam, but internal
Mhm.
exam annually.
Okay. All right. And one of the things I want to make sure, sort of disclosure, disclaimer, whatever you want to call it, the information shared, this is an educational platform. So we want to make sure people are speaking to their doctors and make sure they understand what's
Exactly.
right for them. Your doctor has your history, right? So making sure that you do your due diligence in terms of that. Okay. How about from
Exactly.
are you finished with females?
So I am.
30s?
So with
Okay.
cervical cancer for women in the 30s, and then for men in the 30s, testicular cancer is a more common cancer
Mm,
for men in their 30s. It's more common in men in the 20s and 30s. For this reason, we want our men to make sure they're doing a testicular self exam. What they're doing is they're checking and doing an examination to make sure they don't feel any lumps or bumps in the testicle area. And when you come in for your annual exam, men, when you're in your 30s, you are to get an exam annually where we're checking testicles for lumps or bumps. And if
okay.
we do find any, we do additional testing just to see what's going on exactly.
Yeah. And it's interesting because I don't know, I've never heard, and I have young men in my family, but the screening for that, never heard about that at all.
Mhm, mhm.
So, and this is why this conversation is so important to make sure that we're
It
trying to,
is.
you're getting ahead of stuff because we know, again, once you get to the point of a diagnosis or anything like that, I know it plays on your psyche and how you show up, right? Which is why I
Exactly.
thought it was important to have this conversation because I've seen it. I've seen it happen. Okay. Pivot to the
Yeah. And that's
Go ahead.
that's what I was just gonna say. That's one of the reasons you want to make sure you find someone that you can trust and build that relationship with. And they're
Mhm.
going to take the time to explain things to you so that you know that you're getting the maximum that you can for your health, and
Yeah.
making sure that you're doing all the different things that need to be done to make sure you're taking care of yourself.
Okay. So 40s for
Okay.
women. Yeah.
So
What should
40s
we be
for
thinking of?
women,
Mhm.
we start with mammograms at the age of 40.
Mhm.
And so all women need at least a baseline. Some insurances will cover a baseline mammogram before the age of 40, but definitely at age 40. What I explain to patients is the risk of cervical cancer decreases with age, but the risk of breast cancer does increase as we get older. And so
Okay.
annual mammogram screening is recommended. Some uh, diagnostic centers will offer free mammogram screening in the month of October. So if you
Okay.
know someone who doesn't have insurance, who can't get their mammogram because they're unable to afford it, have them look for resources in the month of October where they can go for mammogram screening. I also recommend that you go to the same facility every year because if you have an abnormal mammogram, one of the first things we're going to want to do is to compare your current mammogram screening, the images to your previous mammogram images. And if you go on to another facility, it's going to take some time to get those images from one place to the other. And if
Okay.
you're a patient in that situation, it is a very emotional and stressful time when you're waiting
Mm,
to get those results sent over. So do
yes.
encourage annual mammograms as much as you can at the same facility.
Mhm.
Also, for breast cancer, I want you to also make sure you're doing a monthly breast self exam so you can get comfortable with what's normal, what's not normal. What I'll tell my patients because they'll say, I don't know what I'm feeling for. And so I tell them once we do their physical, go home tonight and
Mhm.
do your breast exam so you can feel what's normal. And if you feel anything different, then you need to let me know and we can kind of go from there.
Yeah, and I
In
know
addition, mhm,
yeah, and I know that piece is in the annuals are so important because, your monthlies are so important because there are times when you may see something or feel something that, between your exams, right? Because 'Cause you're
mhm,
doing those
mhm,
exams, what, annually, right?
annually,
Annually,
once a year.
yeah.
Uh-huh.
So, it's so important, and I know for me, it might be TMI for some people, but I know I have very cystic breast.
Mhm,
And thank God it wasn't anything, but me being able to know that that's what I had was
mhm.
important, right? Through those monthly
Right,
exams.
right.
So, yeah.
And
And
what I
woo-wee.
recommend, Michelle, is to do your breast exam the same time of the month. If you're
Okay.
a young lady who's having a menstrual cycle, you want to do it after your period goes off because your breasts you get a little bit lumpier and tender right before your
Mhm.
menstrual cycle.
Mhm.
So if you do it after, it's going to be a more normal exam. And also, if you're a woman who is no longer having menstrual cycles, pick the same day of the month to do your breast exam. I
Okay.
also encourage people to have buddies. So if I have a patient as a sister, I'll say, you be your sister's accountability partner. You make sure she's doing hers monthly and also make sure she's
Mhm.
getting her mammograms done annually. And so having an
Mhm.
accountability partner also does help.
Um, any reason why you would start getting your mammogram sooner than in your 40s?
Absolutely. And so if
Okay.
you're someone who has a family history and it's only a first degree relative, so what
Okay.
that means is a mother, a sister, a daughter. If you have a first degree relative with a history of breast cancer, typically we have you start your mammograms 10 years before the age of diagnosis. So if
Okay.
I have a mom who was diagnosed at age 45 of breast cancer, then I would start my mammograms at 35.
Okay.
What I typically will do is I will refer patients that have a strong family history of any kind of cancer in particular, but specifically breast cancer. A lot of the health systems in the area do have breast clinics.
Okay.
I'll do a referral to the breast clinic, and then they'll have them do genetic testing to see what their risk is. If the cancer is one that is hereditary and a higher risk of being transmitted to different generations, as well as ordering additional tests. What I found
Mhm.
is that sometimes you'll get a mammogram done annually or every other year, depending on your risk, as an additional way of screening for breast cancer and those at a high risk.
Okay. And what about males when it comes to that? Because I've heard,
Mhm.
probably about a couple of years ago, I mean, males can be susceptible to breast cancer as well. So when should a male get, examined?
Exactly. So men have there's a 1% incidence of all of the different breast cancers.
Okay.
1% of those patients are males. And so males
Okay.
absolutely can get breast cancer. And so if there's ever a palpable lump, if you can feel a lump in your chest or breast, I actually did have a patient many years ago, a male patient who did have breast cancer. Had a
Mm.
lump, it was near his nipple, and they do unfortunately have to get a diagnostic mammogram. And so the diagnostic mammogram, women that have had mammograms, we know mammograms are not comfortable. And
Ooh.
so if you're a male with not much breast tissue, it's really uncomfortable. And so I'll tell patients, I have to send you for a mammogram and it's not going to be comfortable, but it is necessary.
Mhm.
And so
Mhm.
definitely if a male feels a lump in his chest in his breast area, he does want to definitely get that checked out.
Okay. So they should also be examining their breast area as well. Chest area.
Exactly. Get to
Okay.
know your body. Look at your
Okay.
skin. Make sure you're checking your breasts. Get to know your body.
Okay. Men in their 40s, any other exams?
So men in their 40s, actually men and women in their 40s. And so this is a new change probably within the past 2 years. Colon
Okay.
cancer screening has changed. And so it
Okay.
used to be that we started colonoscopies and colon cancer screening at the age of 50. What we have found is that African Americans, when we find out that we have colon cancer, it's much more progressed to the point
Mm,
that they have decreased the rate age of recommending screening to start at age 45 instead of 50.
okay.
And so men and women age 45 and older should start getting colonoscopies. I did have a little bit of data. So colon cancer affects 150,000 Americans, and 50,000 Americans die annually of colon cancer. Men are more likely to be affected than women. And again,
Mm,
it is typically more aggressive in African Americans when it is diagnosed than it is in other patient populations.
yeah. Oh, yeah.
Yeah.
Yeah. And unfortunately for me, I don't know of any history, but I've had problems in the past. So I actually had to start mine when I was in my 30s and
Hmm. Hmm.
had to get it done like every 5 years. I think this is the first time
Yeah.
in a long time that they had told me I don't have to go back for a longer period of time, which is good, which is a blessing.
Right. Right.
Yeah. So males more prominent, colon cancer is more prominent in
Than
males.
women.
Okay. All
Yes.
right.
And
And
then
I
the
know the
other thing too with colon, I was going to say with colon cancer, every 10 years is what's recommended if it's a normal screening exam. But if you do
yeah,
have a polyp, or if you do have an abnormal colonoscopy, sometimes you'll
mhm,
have to do. I have had some patients that have to get them annually. Some
yeah.
patients with things like Crohn's disease, they have to get more frequent colonoscopies. But
Mhm.
typically every 10 years, but it could be every 3, 5, or 7 as well. You do
Okay.
want to make sure you get your colonoscopies done. And then there are other ways to check for colon cancer. There's something called a FIT test, which is an annual screening. I will negotiate with some patients who will absolutely positively not have a colonoscopy that they can do the FIT test.
Okay.
It's not as accurate, of course, as a colonoscopy, and it's a once a year collection of stool. You mail it to the clinic. We run the test, and then we get the results. If it screens positive, then you do need to get a colonoscopy. That
Mhm.
one's annually, and then there's Cologuard. Cologuard is once every 3 years for most patients. Some patients
Okay.
have to do it a little bit more frequently. Same thing. If it comes back positive, you definitely need a colonoscopy.
Yeah,
When you're
because you
prepping
definitely
for
have
these tests, uh
mhm.
huh.
I was gonna say,
I was
because
gonna
I
say,
know ooh-wee, trying to get ready for these tests. I remember a comedian talking about it, and I'm like, everything he talked about, I'm like, it was so real. I mean, it is a process.
it is.
It is a
But
process.
the thing I tell patients is you'd rather go through a colonoscopy than to have to
Mhm.
deal with chemotherapy,
Yes.
radiation, and
Yes.
all of those things that go along with cancer diagnoses, especially if you wait until it's spread.
Yeah. Yeah. What other screenings, Makeba, 40s, male or female?
I was going to add with colon cancer screening, one thing you want to do when you're preparing for it is to avoid foods that have red dye in it, red food color in it for about 3 to 4
Mm,
days while you're prepping for the procedure, because it can sometimes give the appearance of blood when they do the exam, but we know it's not blood, but we really don't
mhm,
know that just looking at the appearance. So nothing with red food coloring in it for several days before as you're prepping for your colonoscopy.
mhm. And when they say don't eat, don't eat. I made a mistake
Don't eat.
last year. And it happened so fast. So I did it early in the morning. Um, and I had I don't know, I grabbed green grapes.
Uh-huh.
And as soon as I put it in my mouth, I was like, "Ah."
Forgot.
And they would not do the exam. They would not do the
They wouldn't.
exam.
They
Mm-mm.
won't.
They won't do the
Because there's a
exam.
risk of aspiration with that. So if you've eaten before, because with a colonoscopy, I don't know if those of you that haven't had one before, you do have to be put to sleep. So you get an IV put in, they give you medicine through your IV, you have to be put to sleep. So you do have to have someone take you to the appointment so they can drive you home. But
Yeah.
when you are being sedated and you've eaten, there is a risk of aspiration where food can go down into your lungs and cause breathing problems or even pneumonia. So that would be one of the reasons why we don't want you to eat before the procedure.
Yeah. I just, like I said, I put it in my mouth. As soon as I did it, I was like, I'm gonna see. I'm gonna see if they're gonna take me. They're like, Miss Michelle. Yeah. So anyway, don't eat. When they say don't
Don't
eat,
eat.
don't eat.
Don't
Yeah.
eat. And I
Yeah.
will add too, so if you have a colonoscopy with polyps, you cannot go back to doing the Cologuard or the FIT test. So those are
Mm,
some of the requirements. You have to have had all normal screenings up until if you transition from the colonoscopy to the annual or every 3 year screenings.
okay.
You cannot
Okay.
go from having had polyps to doing the easier tests, the FIT test and
Mm-hmm.
the Cologuard.
Mm-hmm. Okay. What else in your 40s, Makeba?
So there are several screenings that are based on our health history and our social history. Social history being cigarette smoking is one of the bigger factors that contributes to a lot of different cancers, and
Okay.
also other issues that we could have as adults. So I talk about the aortic aneurysm screening. So your aorta is your largest artery in your body. It's
Mm,
around the heart and it carries blood to all different parts of your body. And so the aorta, if you smoke, so that vessel can become thinner and thinner to the point it can
mm,
actually rupture. And if you know anyone that's had a ruptured aneurysm, most people do not survive that. And so for that reason, we discourage, that's one of the reasons we try to have patients not smoke and help them to quit smoking as much as we can.
mm-hmm.
Um, Individuals with a history of smoking do have a much higher risk of having this and should have at least one screening at the age of 65.
Do you have
So
to,
if
so
you
do you need to ask your doctor to do that? Like when would someone know? Most people
as
know
long as
go ahead.
no, go ahead, Michelle.
I was going to say, my sister had a burst brain aneurysm 2 years ago.
Mhm.
Smoked in the past, but not, not a long history of it. But and she's, she's a runner, very athletic, and she survived. She was one of the, God's blessings to us, right?
Mhm, mhm.
And doing okay. Um, but I don't know if I would go to a doctor and just say, "Hey, can you do a" So when should you ask for that screening?
So typically, it's not routine that we screen women. We do
Okay.
routinely screen men because there's a higher risk in
Really?
men. However, I've had two patients who have had abdominal aortic aneurysms. They've
Mm,
survived. One ruptured, but they've survived. Um, but we wouldn't routinely screen them.
okay.
Sometimes we'll find some of these issues on accidental or incidental findings when we're doing a CT scan of the abdomen. We may
Okay.
accidentally see an aneurysm, or we
Okay.
may see plaques in the
Okay.
aorta, which means you probably need something to manage that. But for men, definitely when they're 65 and older,
Okay.
some health systems have it set up to where if the patient has been transparent that they've had a history of smoking,
Okay.
based on them sharing that, it does trigger a reminder in the system that
Mhm.
we need to make sure we're doing an aneurysm screening for this patient when they turn 65.
Mhm. Mhm. And my sister, hers was a brain aneurysm.
Right.
So,
Okay, so
yeah.
it's a little bit,
It's just a
yeah, a
little
little
bit
bit
different.
different.
Yeah, yeah. Someone just asked a question. Imma show it since we're talking about this topic. So,
Okay.
my dad had a pulmonary embolism. Should I get screened? So what
There is a screening for pulmonary embolism or
okay.
emboli. A pulmonary embolism is basically where you have a blood clot in your somewhere in your body, typically your
Mhm.
lower extremities, your legs, and it will break off from that vessel and travel to the lung, and it becomes a
Mm,
pulmonary embolism. They can be deadly. So when you have someone who has a pulmonary embolism, it's kind of a medical emergency where we want to get them managed. They're put on blood thinners, and then they're usually managed with blood thinners most of the time for the rest of their lives. Sometimes we'll manage it for a shorter period of time. Again, this depends on your personal health history,
mhm,
and this is determined by your primary care provider. Risk factors for pulmonary embolism, again, cigarette smoking is probably one of the big risk factors
mhm,
because it does have a tendency to cause clotting. Also, sedentary lifestyle. So, if you're sitting most of the
mm,
day, not doing much walking, it allows for blood to pool in your lower extremities and clots to form.
right.
For women, some of the risk factors are estrogen. And so, especially as we get older, women over 50 should use estrogen cautiously because you do have a tendency to have clots to form. And then
Mhm,
those can lead to pulmonary embolism. We have seen with COVID, and you all probably have seen this, we have seen an increased incident of blood clots, pulmonary emboli, from folks that have had either COVID, the disease itself, or the vaccine. And there's
Mm,
definitely a clotting tendency that goes along with COVID.
okay.
If you
Yeah.
get COVID, I mean, it's just something that unfortunately does happen to some patients as they deal with having some of the complications of COVID.
Yeah, and Makeba, this is the daughter who said her dad had it. So she's asking, should she get screened? So is that something that's hereditary, that particular embolism?
That's not so the pulmonary embolism is not hereditary
Okay.
unless there is a hereditary clotting disorder. So there's not a
Okay.
screening that we would necessarily do for someone who has a family history of pulmonary emboli.
Got it.
Particularly, Angela, if if your dad had some of the risk factors that we talked about, like cigarette smoking, sedentary lifestyle, recently had a COVID infection. If he had some of those risk factors, then that would kind of explain how he did develop the pulmonary embolism. And because some of those risk factors are social, such as smoking and sedentary lifestyle, that it's not hereditary, doesn't have
Okay.
a family tendency.
Got it. Thank you for that. Anything else in terms of 40s? We kind of skirted over to some other stuff, but anything else?
So that's the aneurysm, and one that I don't know that this is done well enough or often enough is screening for lung cancer.
Mm.
We don't screen, I don't think, enough for patients with lung cancer. Lung cancer affects 1 in 16 men and 1 in 17 women, and there are over 234,000 new cases annually in the United States.
Mhm.
Lung cancer screening is recommended annually for both men and women.
Mhm.
And it typically from my patients will, if they again have been honest and have a history of smoking, it's documented. I get a reminder that they need the annual lung cancer screening. It's
Okay.
low dose radiation, so it's not the high dose radiation that you would get for doing diagnostic screenings. So it's a little
Okay.
bit less radiation. It's a little bit safer. And it's for folks that have had a 20-year pack history of smoking. So I ask someone, how many
Mm.
years did you smoke? If someone smoked for 2 years in college, they don't really need the screening. But if someone smoked for 20 or more years, if they're a current smoker, and they have to be between the age of 50 and 80. And
Between
so for
50
my
and 80.
65-year-old,
Okay.
yeah, if I have a 65-year-old that smoked for 20 years but stopped 10 years ago, then they need a CT screening. If they've
Got it.
stopped more than 15 years ago, they don't need the screening.
Okay.
So there are a few different factors that we look at in order to determine whether someone needs a screening.
Yeah,
I
that's
do have
interesting because I don't know how many people I didn't know there was a screening for lung cancer. That's why this conversation is so important to have. Um
yeah.
yeah, it's just so important to have. So thank you for
You're welcome.
sharing this. So are we ready to move to 50s?
I was going to add one more thing because
Okay, go ahead.
I have some patients that I know no matter what I recommend, they're going to say I'm not doing it. So I'll try
Yeah.
to compromise with some folks. And
Okay,
so
go
for
ahead.
those
Let's
that
talk
will
about that.
refuse the CT scan, I will ask them if I can do a chest x-ray. It's not
Okay.
nearly as diagnostic as a CT scan, but it's better than nothing.
Okay.
So if you have, and the thing about it, I think Michelle, you were asking, how do you wanted to you talk about how to have conversations with your healthcare provider.
Yeah,
Ask
absolutely.
questions. Ask
Mhm.
questions. If you're not willing to have a test done or a screening done, share that with your provider. Help them to understand the reason behind your decision so they can try to educate you and try to give you options if there are options available. Because we want
Mhm.
what's best for you, which is you, the patient, the consumer, to make sure you're around long time for your family and for yourself and be as healthy as you can be.
Yeah. So to your point, and we'll get into this a little bit more detail as well once we go through the screenings, but being honest about your history is so important when talking
Mhm.
to your primary care physician, right? I
Yeah,
know some
it
people,
is.
um, my dad did not like doctors. There are a lot of people who don't like going to doctors, right? But it's so important this day and age to share that information because there's just so many other things that are coming up, and we'll talk a little bit about even some of the newer vaccines, which I had no idea about until like a year or two ago, that it was
Mhm.
something I even needed to be thinking about. So, okay. 50s.
So we went through 50s. So colonoscopy. So
Oh,
make sure you continue
colonoscopy.
to
Yeah,
get
yeah,
colon
yeah.
cancer
Okay.
screening.
Yeah.
Make sure you're continuing to get your mammogram screening,
Okay.
and then make sure you're doing your self exams at home for breast cancer for ladies.
Mm-hmm.
And then when you're in your 60s, again, pap smears phase out when you turn 65. So don't get upset with your healthcare provider if they say you don't need a pap smear,
Okay. Okay.
because that's actually a blessing for a lot of women to be told you don't have to get a
Mm-hmm.
pap anymore. But at
Mm-hmm.
65, you no longer need paps. Again, the reason is because the risk of cervical cancer is pretty much nothing at the age of 65. It's
Mm-hmm.
dropped significantly from when you were in your 20s and 30s.
Mm-hmm. Mm-hmm. Ovarian cancer and things like that. Is there anything? I mean, we hear about it.
Right.
Screenings for that, or is that something that will get picked up when you're doing your OBGYN appointment
So with
exams?
ovarian cancer, that is a cancer of older women typically.
Okay.
It's more common in Caucasian women than African American women. And the
Mhm.
unfortunate thing with ovarian cancer is a lot of times women don't know they have it until it's too late. It's a
Mm.
cancer where they don't know that they have it until they start becoming symptomatic. Abdominal distension. Sometimes you have collection of malignant or cancerous fluid in the abdominal area. Loss of weight all of a sudden.
Mhm.
Those are some of the
Mhm.
main symptoms of ovarian cancer. You're
Okay.
correct, Michelle. When you do have your annual exam, you don't need the pap smear, but a bimanual exam is where we have two fingers and we're checking the ovaries internally to
Right.
make sure that the size, we should not feel the ovaries. They're so small that you should not feel the ovaries when we do an exam. And so if we feel
Mhm.
an ovary, then we know that we need to do additional testing just to see
Okay.
if it's a healthy ovary or if there's something going on there. But
Okay.
unfortunately, ovarian, there's a blood test we can do to detect ovarian cancer, but it's not a
Mhm.
screening per se. If we have
Mhm.
a patient who's symptomatic, then we'll do that blood test to check to see if it's ovarian cancer.
Okay. All right. Any other exams for men in their
So
50s?
for men, just everything we've talked about, men do not no longer need there's one other one we didn't talk about, prostate exam. It's really
Yeah.
important. So
Yes.
men do need to start prostate exam screening. A lot of insurances will cover a PSA, which is the blood test to check for prostate levels at the age of 40. We don't really
Mm.
need to start screening until the age of 50 for the general population, but African Americans, we do need to start screening at the age of 45 because we have a higher incidence of prostate cancer.
Mhm.
We no longer are required to do rectal exams on men. And so years ago, we used to do a rectal exam to see if the prostate felt enlarged. Now it's the lab test, the blood test is so specific enough that we can just do the blood test regularly and yearly,
Okay.
that we
Okay.
can detect prostate cancer from there.
Okay.
With prostate cancer, men usually have urinary symptoms. So they'll have difficulty getting their urine flow going. Sometimes they'll urinate a little bit, stop, go, stop, and go.
Okay.
The change in the stream. The prostate gland sits near the rectum, and it's also over the tube that goes from the bladder outside to the penis. And
Okay.
so that's why there are issues with urination, because if that gland gets enlarged, it can cause an obstruction of that tube that transports the urine.
Okay.
And so I
All
did have a
right.
little bit of information on prostate cancer. Prostate cancer is a cause of death in 1 in 4 men. So it's a really high
Mm. Mm.
mortality with prostate cancer. Higher
Okay.
incident, like I said, in men in their 50s and over. African American men are more likely to get it. And actually, we're 2 to 3 times more likely to die from prostate cancer than non African American men. So when African American men get prostate cancer, it's much more likely to be mortality as a result.
Mm. So the good thing is, because I remember a lot of brothers hesitated doing the exam because of
Hmm.
how
Hmm.
they had to do it before. So the good
Hmm.
news is, fellas, if you're listening,
Blood test.
it's a blood test now, so you don't have that excuse, right?
Right.
And make sure you're getting, it's important for all of us to make sure that we're getting our exam. But I think if there are some men out there who did not know, it's no longer a rectal
You don't
exam. At
need a
least
rectal.
now, yeah.
However,
Yes,
if you
ma'am.
have symptoms, we are supposed to do a rectal exam. So if
Okay.
you're a male that has urinary symptoms and we're concerned that the prostate might be enlarged, we are supposed to do a rectal exam.
Okay.
But what I tell my patients, Michelle, is they should be happy I'm doing it because my fingers are not as thick as some of these male providers that are doing the rest
Right,
of the things.
right, right.
So try to make
Ooh,
light of it as much as we can.
yeah, yeah. All right. 60s. Anything else?
So that's it for 60s. And I
Okay.
will add, you had asked earlier about screenings for breast cancer, but any cancer that there's a first degree relative diagnosed before the age of normal screening, you do want to
Mhm.
get screened 10 years earlier. So, again, with colon cancer as an example, if you have
Okay.
a parent or a sibling or a child, guest parent or sibling that's diagnosed with colon cancer at the age of 49, you do want
Mhm.
to start screening earlier. What I will also have my patients do is to ask their family member who is diagnosed with cancer to ask
Mhm.
their healthcare provider, their oncologist in particular, at what age should my daughter start doing colon
Mhm.
cancer screenings? At what age should my son start doing prostate screenings if I
Okay.
was diagnosed at a younger age? And that will give you an idea as to when we need to start screenings at a younger age than what we typically recommend for the general population.
Yeah. And Makeba, we may have some definitely have some parents who are on the line. Anything they should know about in terms of their children younger than 30? Any screenings
Mhm.
younger than 30 that should be happening, particularly for those in the college years, 20, early 20s?
So when my patients turn 18, I start doing labs and screenings. So with the
Okay.
18-year-old, they're an adult. And so I start with a cholesterol screening, a thyroid screening, a blood count to make sure that they don't have any anemia. Sometimes you can find malignancies just by doing a simple blood count. So
Mhm.
for children, even school age children, you want to make sure that they've had a blood CBC or a complete blood count at least once between 0 and the age of 18. And so we'll
Mhm.
do that. And then when you're going to college, breast exams for young ladies, so making sure they're doing their breast self exams. Pap smears begin at the age of 21. So that
Okay.
guideline changed several years ago from 18, so now it's 21. And
Okay.
because cervical cancer is more common in women in their 20s, we do every 2 years in their 20s instead of every
Okay.
3 to 5 years. And so we do it
Okay.
a little bit more frequently. Um, being sexually active does put you at higher risk for cervical cancer. So again, especially in young ladies that are sexually active, we want to make sure we're doing their pap smears pretty
Mhm.
consistently.
Mhm.
And then for our young men in their 20s, we want to make sure they're doing the testicular self exams. And so
Okay.
I try to teach them how to do that when I do their exams, when they come in for their physicals, and try to, make it something that they're comfortable doing because it's a sensitive exam and it's probably not something most 20-year-old men want to be doing, but it's something that they really and truly need to be checking for because they're the age where they're going to be
Yeah.
most likely to be diagnosed with it.
Yeah. So for the parents out there with 20 somethings, some information for you. And we have a lot of people who are living longer, Makeba. So
Hmm.
anything for those who are in their 70s and for those of us who are taking care of, we're in that sandwich generation, maybe taking care of the kids and our parents. Anything we should be thinking about for those in their 70s in terms
Yes,
of
so those in
screenings.
their 70s screenings,
Mhm.
just continue because a lot of the screenings will phase out at the age of 75. So
Okay.
breast cancer screenings, mammograms, you no longer have to get them. They're not recommended beyond the age of 75, nor are colonoscopies. So colon cancer and breast
Okay.
cancer screenings do stop at the age of 75. However, I do tell my patients that I will continue to get my mammograms 75 and beyond.
Okay.
Insurance will still cover it. And so if the patient wants to continue to get it, that's a sensitive age where you have to let the patient decide what they want to do. So
Yeah.
if a patient is 80 years old, 85 years old, because I have some vibrant 85-year-olds that are more vibrant than some of my 40-year-olds, but
Yeah.
they don't want to continue to do screenings. They've just
Mhm.
decided that I'm happy just the way I am, and I'm not going to
Mhm.
get a mammogram. I'm not going to get a colonoscopy. And as a
Mhm.
healthcare provider, we have to respect their decision to make that choice. But
Mhm.
I do still encourage mammograms beyond the age of 75.
Okay. And I got a question here. It's not related to screenings. Um,
I saw that question,
the
Angela.
menopause, we just finished this. It was a dynamic. We didn't tape it for sensitivity reasons, but it
No,
was
we should
absolutely
have.
a dynamic, excellent um podcast live stream that we did. So you want to touch upon that for a
Mhm.
little bit? So question about menopause
I
for women.
will. Yes. So, Angela, I can empathize. I'll just start with that. So, with menopause, so menopause by definition is when a woman has gone a full year without a menstrual cycle. And so that means if you have a period today and don't have one for 9 months and you have another menstrual cycle, you're not postmenopausal. You have to go full year. As far as treatments for menopause, that's a whole conversation, but I'll try to hit the hot spots. With menopause women, we have hot flashes, we have mood fluctuations, we have difficulty sleeping, sometimes difficulty concentrating. Some of the medicines that I'll prescribe are antidepressants, anti-anxieties at very low doses, and I have some ladies that do extremely well with that. There are some that I prescribe more so than others because of side effects, and it also depends on the patient. And so Paxil is one that I use often. Wellbutrin is another one that I recommend. Um, Estrogen is an option. And again, as I said earlier, when you use estrogen, there are some increased risks that are associated with estrogen with some cardiac events. And so I use estrogen very sparingly, and I will typically, as a primary care, have a patient follow up with their gynecologist if they want to do estrogen therapy. You have to also be careful with estrogen because there is a link with certain breast cancers and estrogen. And so we want to make sure if a patient has a history of breast cancer, they absolutely do not want to do any kind of estrogen replacement whatsoever.
Mm-hmm.
Some non-pharmacological or non-prescriptive medicines are black cohosh, which is it's an herb that does help with hot flashes. And so that works for some ladies well, and for some ladies, they say it doesn't work at all. But I think it's worth trying because it's not a medication that is a prescription, and it's been around for years and it's very safe. Um, Ashwagandha is another one that the ladies are taking now for hot flashes. Also helps with the mood swings and the mood fluctuations that go along with menopause. That's also an herb that is over the counter as well. So those are a couple of options. Journaling, exercising, walking, all of those are things that help with menopause as well. It is harder for us to lose weight when we start to go through menopause. So I encourage my
Mm-hmm.
ladies in their 30s and 40s to make sure they're exercising and getting their weight where they want it. So when they become older, 50, a little bit more experienced at life, they won't have as much difficulty with weight loss because they'll
Mm-hmm.
already be set with their exercise regimen.
Mm-hmm. Thank you for that, Makeba. And Angela, thank you for your questions. So let's talk about some of these other vaccines that have been popping up, especially for those of us who are older in age, right?
Mhm.
Um, we all know about COVID vaccine, and Lord knows there's probably a lot of conversations about that. Um, Talk to your physician, everybody, please, because they know your history and all that other stuff. But RSV, Shingrix, and pneumonia were the three that are recommended for those people who are over 50 and 60. Talk a little bit about those, and if there's any others that people should know about, and what should we be considering in terms of getting it, risk
Okay.
factors, things like that, Makeba.
So I'll start with tetanus. Tetanus is a basic vaccine or immunization that we've all been aware of for years. And that
Mm-hmm.
one is once every 10 years. If you have a nasty cut or injury, sometimes we'll reboost you after 5 years.
Okay.
That is one vaccine. And I'll talk about because coverage is different for patients that have Medicare than for patients that have private insurance. And
Mm-hmm.
so for my Medicare patients, you cannot get a tetanus vaccine in your primary care office, at least where I am, you cannot because your
Mm.
insurance company won't cover it. We recommend that you get the tetanus vaccine at the pharmacy so you can get better coverage.
Okay.
However, if you have a cut or an injury, then it's going to be covered because we're protecting you from the laceration or whatever that injury is, and you can get it in
Okay.
primary care at that point.
Okay.
Um, yes, so then I was actually Kim. I'm going to shingles next. So shingles vaccine is Shingrix. So we did have Zostavax years ago. And what you'll find with some of these vaccines is there'll be one vaccine, and then a couple of years later, there's another one. And so folks will say, well, I've had shingles vaccine already. But as we know, we try to get we get better coverage with vaccines as they evolve. And so the current vaccine is Shingrix, which is for shingles, and it is recommended for patients 50 and over. It is a 2-shot series. And so you get the first vaccine today, and then you get your second one 2 to 6 months after. However, if you do not meet that 2 to 6 month window, you can still get it even if it's a year later.
Mm.
Most vaccines that are multi-dose vaccines, you do get pretty good coverage from the first vaccine, but I do recommend following up with the second vaccine as recommended. So what shingles is caused by varicella. And I was at a conference the other week, and they said that over 90%, 95% of all individuals will have the varicella virus in our bodies, either from having had varicella, which is chickenpox as a child, or
Mm.
either from having had the vaccine. All kids that are pretty much 27 and under have had vaccines for chickenpox because that's now a requirement for entrance into school. And so we have the virus in our bodies. It lays dormant, so it's hidden unless there's stressful events. And that can be physical stress on the body. So if you get sick, that can be a physical stress that can trigger an outbreak. Or if you have emotional stress, that can cause an outbreak. And so
Mm.
shingles presents as a very painful rash. It's typically on the abdomen, and the
Mhm.
back kind of wraps around in what we call dermatomes of
T-zone,
nerves. It follows
T-zone. They
nerve.
call it like the
Those T.
T-zone.
Yep.
I've had it before, so that's where I had
Yep.
mine is in my T-zone. Yeah. Yeah.
Yeah. And it gets in those nerve endings, and it is extremely painful. I had a
Mhm.
patient who came in. She had abdominal pain. And so I brought her in and I did her exam, and she lifted her shirt and she had shingles. It wasn't abdominal pain, but it hurt so bad she thought it was abdominal pain. And for
Mm.
her, unfortunately, she has permanent nerve damage. And so
Okay.
it can damage your nerves indefinitely. So I strongly recommend shingles vaccine. I see a couple of my friends on here, and
Okay.
they've made me ensure that I'll tell my patients that it does hurt. So the vaccine does. It's not a, it does cause pain. Um, but the pain that you have from the vaccine is a lot less than the pain that you would have from shingles. So you can
Mhm.
deal with a sore arm for a day or two versus the risk of having permanent nerve damage from having had shingles. So
Mhm.
absolutely, 50 and over, Kim, get your shingles vaccines.
Anything else? RSV
In terms,
and this
yes.
pneumonia. Yeah.
So pneumonia vaccine, we typically will recommend the Pneumovax 20 is the current pneumonia vaccine that we're giving. There was a Pneumo 13 previously, and so if you've received the Pneumo 13, your healthcare provider will recommend another pneumonia vaccine. So if they do, it's because it's an updated vaccine that has different strains of pneumonia in it. So the Pneumo 13 covers 13 strains of pneumonia. The Pneumo 20 covers 20 strains of pneumonia. And so what it does is it helps to prevent the strains that are in the vaccine, which are the common strains, if you were to become exposed. And so patients that are high risk should get a pneumonia vaccine before the age of 65. So that's going to be your diabetic patients, your patients with heart disease, your patients with asthma, patients with
Mm.
any kind of lung disease. Your healthcare provider is going to recommend that you get the pneumonia vaccine. Um, Once you turn 65, if you've had the vaccine before 65, you're going to need a booster. So you're going to
Okay.
need to get revaccinated at the age of 65. If you've never had a vaccine before, then you'll get your first one at the age of 65. And then you'll get
S
a booster 10 years thereafter, every 10 years.
So the pneumonia vaccine is recommended whether you have, um, any of those
Mhm.
indications or not. Still recommended for
After the age
those over
of 65.
65. Okay. All
I
right.
do. I do. And
And then
there's some vaccines. Uh-huh.
go ahead,
I was
finish.
gonna say shingles is one. I tell my patients that they're gonna hear my mouth about it and every time they come in until they get the shingles vaccine because it's one
Mhm.
that I do strongly believe in. Same thing with
Mhm.
pneumonia, especially for certain patient populations. Those that are
Mhm.
high risk, I want you to make sure you're vaccinated against it.
Yeah. So RSV, my understanding is not new, but it seemed like we just heard a whole lot about it over the past
Hmm.
2 years, 2 or 3 years,
Right,
right?
right,
Yeah. Talk a
right.
little bit about that.
So RSV is a respiratory infection, and it does affect children under the age of 2 and adults over the age of 65 a little bit more than those in between. And so, what Michelle is speaking to is that we've heard about RSV vaccine. Historically, it's been in children. And so, we've been vaccinating kids with RSV vaccine. Those are high risk. So, those kids that have asthma and other respiratory infections or histories that would make them at high risk from getting this infection. It's a virus. So, the thing about viruses is you cannot treat them with antibiotics. They tend to have to
Mm,
run their course. And so, you can't get antibiotics. They do make antiviral medicines. There's not one for RSV, but we do have ways of treating it. But the RSV vaccine is recommended for individuals that are over 65. And again, that vaccine is covered better at the pharmacy. So if you have to
mm,
get the RSV vaccine, I would recommend that you get it at the pharmacy. And I would like to allay concerns of folks getting vaccines at the pharmacies. The pharmacists have become very astute with giving vaccines, especially since we've had COVID, because
yeah.
they are the ones when we get COVID vaccines, they can do COVID, tetanus, pneumonia, RSV, shingles vaccines at your pharmacy. So if you can't get it at your primary care office, you can always get it at the pharmacy, but Medicare does prefer that the shingles vaccine and the RSV vaccine are two that are recommended at the pharmacy versus your primary care.
Hmm. Is there anything, because I know some physicians would recommend, or they say it's okay to take certain
Hmm.
vaccines at the same time or
Hmm.
not. Thoughts
Hmm.
around that?
I
I know
do.
I've had 2 at the same time that I would never do again. I won't say which ones, but, yeah, but thoughts around that?
It depends on the vaccine. So you
Okay,
can do some, I won't do more than two in adults at the same time. And it
okay,
really depends on the combination. Um, COVID vaccine, I'll give with the flu vaccine on the same day. Most people
okay,
do fine with it. They may have some soreness at the injection site. Pneumonia and flu vaccine, I'll do those together. Shingles vaccine, because we don't do a lot of the RSV vaccines for patients over 65. We don't give a lot of the shingles, and the shingles for patients over 65 at the pharmacy too. But shingles and tetanus, I'll do at the same time. I actually received both my shingles and my tetanus at the same time
mhm.
because in my mind, I was not going back to get a vaccine in a week or two because it's just not convenient.
Yeah,
And so
yeah,
for
yeah.
convenience sakes for me, I did both of them.
Okay,
And but generally speaking, most vaccines are safe to get together. Your healthcare provider can advise you of which ones they feel comfortable with giving you together.
mhm,
Some I don't give together. Sometimes shingles and COVID, I'll split those up because they both have potential to have side effects. And so
mhm,
to
mhm,
minimize the risk of side effects, I'll have you get one today and come back next week and
mhm,
get the other.
hmm. Thank you for this. And again, the reason I wanted to have this conversation is um I know, well, one, like I said, amongst my friends, we've just been talking about a lot of this. It must be the
Mhm.
age group that we're in right now. But you contract any of these things, I tell you, it will um make you be a totally different person.
Mhm.
You show up
Mhm.
as a totally different person, and it impacts how we show up, right?
It does.
So it's important for us to ensure we're staying on top of these things, getting our
Mhm.
screenings, preventative care, right? To your point, that's just preventative care. So anything you can do to protect yourself is of value. So I appreciate
Yeah.
conversation about that. Let's talk about, because and I know one of my friends, we had this conversation about the bedside manner of doctors, and she
Mhm.
not feeling comfortable like her doctor was addressing her issue. You
Right.
being a regional medical director, working with doctors and offices and things, what advice would you give to patients who are coming in and seeing doctors? What's the best practice in terms of engaging with your doctor?
Asking questions. So
Mhm,
asking questions, if they use a term that you don't understand, ask them to explain it.
mhm,
Asking questions about what you need to do about your health. Someone asked about non hormone replacement therapy for menopause. So, if you're someone who doesn't want to do prescription medication, what other options do I have to help to manage my health care?
mhm, mhm,
You want to find someone that you're going to feel comfortable with. What I have found, Michelle, is that in this day and time, patients want people to care for them that they feel comfortable with. And a lot of time we found this with COVID, and we've actually had conversations with around this, that people want people to take care of them that look like them, is what I find.
Mm, mm,
They feel more comfortable with someone who has that same appearance because they're more relatable. Unfortunately, that's not always the case, and you can also find a great healthcare provider who may not have that same appearance but has a personality that clicks with you. So you
mhm.
want to read your bios online before you schedule an appointment with a provider. You want
Yeah.
to read reviews. You want to see what do patients have to say about this person. Most clinicians have a video. Look at the video. See if it's someone you think you can engage with and feel comfortable with. You
Mhm,
don't want someone who's going to come in and look at the computer and not look at you as the patient during the visit.
mhm.
Um, if you don't know a lot or not comfortable asking questions, take a family member with you. So take
Okay.
someone with you that can ask questions and can write down information and translate it for you. I tell patients all the time, I'm a person just like you. And so I'm not going to treat you any differently than what I would want to be treated as a patient. And so I think
Mhm,
that's important.
mhm. Yeah, and then we have those who are just fearful of doctors too, right?
Mhm.
Anything you recommend to help ease that as well?
So I have some that I hear that a lot. I hate coming to the
Mhm,
doctor's office, but I don't mind coming to see you.
mhm,
Or my
mhm,
blood pressure's up because I have white coat syndrome,
mhm.
which means your blood pressure goes higher when you come into the office. I think the more you see that individual, the more you become just like any relationship.
Yeah,
I tell
absolutely.
folks it's like the first time you meet a provider, it's like a blind date. You don't know who you're getting. I don't know who I'm getting. The benefit is you get to pick me, but I may not always get to pick you. And
Right.
so you get to shop around, you get to date and figure out which provider you want to give your health care put in their hands, because you do want someone that you can trust, because you have one body, you have one go at
Mhm,
this life, and you want
mhm,
to do everything you can to take care of yourself. And so I
mhm,
think just finding someone, building that relationship, going for your visits, asking questions, remembering that we're people too. We have issues that we may not share with you that impact us from a physical, emotional, whatever standpoint. So
mhm,
we're human too. One of the things that I'll share, and my mom is on here and she's heard me say this. One of the things that
mhm,
I'll share is that, especially when you go to the specialist, because with specialists, you may not see them as often, so you may not be as comfortable with the specialist as you are your primary care.
mhm,
But sometimes have my patients ask the specialist if they're trying to make a decision about the treatment plan. Ask them,
mhm,
what would you do?
mm,
If you were me, what would you do? If I
mm,
were your mom, what would you do? If I were your
mhm,
sister, what would you do?
mhm,
Um, and sometimes when you get that nonverbal expression, that's your answer.
mm. That's good. That's
Yeah.
good. Yeah. Yeah. Last question for you. Urgent care versus going to see a doctor versus um emergency room.
Okay. So with primary care and urgent care, so usually what I would recommend is, especially if you're connected to a larger health system,
Mhm,
call your office and have the nurse triage you, and they can give you guidance as to where you should go.
mhm,
That guidance is determined about by the care that you'll likely need to get the care that you need. So
mhm,
with primary care and urgent cares, we do have the capability of doing X-rays at most of the sites. Some sites can't do X-rays. We don't have the
mhm,
capacity to do CT scans or ultrasounds.
mhm,
So for someone earlier asked about a pulmonary embolism, you're going to need a CT scan. That cannot be done in the in urgent care or primary care. You need to go to the emergency room. I would
mm,
recommend calling your office, having your call triage, and then they'll direct you as to the best way to get the care you need.
mhm, mhm.
If you can't get into your primary care office, because I know access is a challenge this day
Yeah,
and time for a lot of folks, urgent care is the next best option, and they will get you to the ER if you need to be transported to the ER. We
yeah.
transport patients to the ER from primary care as well. Um,
Okay.
so it really just depends on, what your needs are as to where we're going to take care of you.
Thank you, thank you, thank you. Any other questions from the audience? And I can see those of you who are on YouTube and Facebook. But any other questions while we have Makeba Felton as my guest for tonight's episode? And what I'll do, y'all, I'll share um Makeba's information again. So that for those of you who want to connect with you, are you taking new patients? Do you taking new patients, Makeba?
Unfortunately, I'm not Michelle, and I feel so bad when I have to tell patients that because
Yeah,
again,
yeah,
people want people who look like, and I have, I do have several practices that I work with, and
yeah.
several of those practices are also taking new patients. So if I can't take care of you, I'll find someone that can help you as best as I
Thank you,
can.
thank you, thank you. Well, I appreciate you for kicking off this series, Healthy You series. And as I said, I know as a coach when I'm dealing with someone and if they're dealing with stress, to your point, there's a lot of things
Mhm,
that could cause stress in someone. And when I'm coaching someone through, what may seem on the surface as a workplace issue or um, something very innocuous. It just a lot of times there's more to what's happening to them
mhm,
than
mhm.
just the pressing issue, which is why
Exactly.
I feel like this topic of healthy you is so important, right? There's fitness and nutrition, but we also need to make sure that we're doing things medically preventative care.
Mhm,
Next month is Mental Health Awareness Month. So I will have two therapists on, and that topic is mental health in the workplace, right? So,
mm. That should be
um,
good.
yeah, yeah, I have two great people who will be joining me for that discussion. So I'll pop tell people what date that will be. And then I also want to deal with spiritual health, right? Because again, if any of
Mhm.
those things are not aligned, it can wreak havoc. It can wreak havoc and cause us to not show up as our best. So
Exactly.
my reason for doing this. But I'm gonna put you in the green room and
All
I will
right.
meet you
And I
there.
appreciate
But
everybody's questions
thank you for the
and
questions.
thanks for the
I
opportunity.
Yeah, and I don't see any other questions. I'm just checking one more time. Don't see any other questions. But thank y'all for hanging in there and asking your questions. You understand my why for doing this because I know I had some people's like, oh, executive coach, career coach, why are you doing this? It's important, y'all. It's important in terms of how we show up. And I do believe in a holistic approach to just looking at what may be causing issues for people, even my coaching practice. And if it's non-health related, because I don't deal with health stuff, but I try to look at what else is going on around that's causing someone to be stuck or having an issue and things like that. No different in terms of our health and the things that could cause us to be stressed. So, this is why I'm having this conversation. And as I mentioned, next month I'll be talking about mental health in the workplace and looking forward to that discussion. Just stay tuned. Stay tuned into my Facebook page if you want to know when it will occur. And I'll also be posting information on my website. For those of you who do not follow me, you can follow me on www.mybesteveryday.com. That's my webpage / video podcast. My Facebook business page is facebook.com / my best every day. Okay. But I appreciate you all joining us on a Thursday. And happy Friday Eve, everybody. And have a great weekend. Until next time. Bye.
Bye.